Fred, thank you very much for joining me for this interview. It's a great pleasure to meet with you and hear from you the story of your career, and obviously you are a champion of the management of women with breast cancer, and we're all, very grateful for the work that you do at UM, at the middle school, at UHealth, and I'd like to help the world understand how you got to do what you do, and maybe go a little bit deeper than usual into your personal history in a way that we can understand better how you managed to take the steps that took you to such a success. So can you tell us a little bit about
Sure.
how you grew up and how that passion for saving the life of women with breast cancer came about in your career?
Thank you first of all for having me. I was actually delivered by my grandfather in a city just 8 miles from the U.S. border. My mother's American, my father's Canadian. I grew up in Toronto. My grandfather's 4 sons were all surgeons, and so I was the firstborn. So through no pressure from them, I just found myself going in that general direction. I went and did my medical school at a different place from any of the 4 of them. That was as far as I varied off the family path. But I decided to go into surgery after medical school because it was the broadest field. At that time, general surgery was and still remains really the best generalist specialist field that there is. And I went through residency in Toronto and was lucky enough to do 2 consecutive years as chief resident because they ran out of warm bodies ahead of me. And in the second of those years, I spent the first of them in the west end of Toronto along the main artery into the city, so did a tremendous amount of trauma.
Yeah.
And there were only 2 of us, and one of us had to be in the hospital all the time. So at the end of that, I got down to the Toronto General, and I had every intention of going into private practice in Canada. But I sort of looked around me, having interned there 4 years previously, and I said, I'm not sure I can just walk away from this without at least trying to do something academic. And because you had to have your Royal College exams, which only occurred 6 months after residency, there was an obligatory time where you had to do something other than clinical medicine.
Yeah.
And so I said, well, I'm going to go with my colleague, with the person who I trained with or worked with at the General, Rudy Falk, and went into the lab for 2 years, which was probably the best thing I've ever done in terms of reorienting a career. It was in the second of those 2 years when I got a phone call from Miami, out of the blue, from someone I knew nothing about, and that was more my ignorance than anything, because this happened to be Steve Rosenberg's predecessor at the NCI as the chief of the surgery branch, Alfred Ketchum, who was a wonderful guy, and when you hear him over the phone, you can just hear the optimism coming through. And this was in October, and I'd just had an experiment that fell flat on its face and was, it was not a good morning. But he talked to me and he said, "We're looking for a surgical oncology fellow." And again, in concert with being a general surgeon, there's only 3 things you can do in general surgery that'll keep you general. One's trauma, one's pediatrics, and the other is oncology. So my parents lived in Sarasota at that point, so I came down at Christmas, and on the day after Christmas, in 30-degree weather, I took a pedal pusher airplane from Sarasota to Miami, interviewed for the day, and came in
What year was that, Fred?
This would be December of '83. Started my fellowship in July of '84 for 2 years. Alf offered me a job, and I was really torn because I had him, and then I had Rudy Falk back in Toronto, and I actually went back to Toronto, and it became very clear very early on, because of the strictures then existing in the academic system, that was a mistake. And Alf, I talked with him, and he said, "We have a place for you," and so I was back in January of '88. Been here ever since.
Great.
It's purely by accident.
And tell me, why do you think they called you? I mean, there must have been many surgeon chief residents that were at the same level at that specific time. of history. So why do you think they called you first? There's quite a bit of distance between Miami and Toronto.
It's actually fairly simple. David Robinson, who was also on faculty here, had been at Memorial Sloan Kettering with one of the people who was 4 years ahead of me in Toronto, Lauren
Okay.
Rothstein. And they were, Miami was looking for a fellow, so they talked behind sort of in the background. And my name got to Alf and he called me.
And I'm sure that your talent at the time was already, I mean, to be chief resident is already a recognition of an individual's talent, but you must have been particularly recognizable among your peers in the way that a place that was not exactly next door would call you to recruit you.
Well, that'll be for others to say. I would say that word of mouth is how I got here. It's you know, the most interesting thing about life is what happens in an unplanned way.
That's exactly right.
Yeah.
And so, okay, so here you come, you know, Canadian from Toronto, and you arrive in Miami in the mid-'80s. That must have been a pretty big change for you.
It was a bigger change than you know. We moved we moved from Toronto, where it was 70 degrees and 40% humidity, to Miami, Florida, where those numbers were both 95, and we moved into an unair-conditioned house 6 miles inland. And my grandparents lived in Sarasota. I knew bloody well what Florida was like, but it was just one of these unbelievably stupid things. But we spent 6 months there. We were the only Anglos in a Cuban neighborhood, and they absolutely took us under their wings. It was the most phenomenal experience. I mean, they're very family-oriented people. So we left after 6 months because we couldn't take another summer like what we'd just been through. But it was a great introduction to Miami.
That's phenomenal. And tell me, so I understand that your family was spending some time in Florida, I guess for vacations of things of that sort.
My parents left Toronto in 1977. They moved permanently to Sarasota
Okay.
at that point.
Okay.
And my grandparents, her father and stepmother had lived in Sarasota since the 40s.
Okay. And so that was your entire family. Did you have did you have more family than that?
Three younger sibs.
Okay.
Two sisters who are still in Canada. My brother is an engineer at the National Institute of Standards and Technology in Washington. And if you look at his PhD thesis, you'd have better luck trying to read Swahili.
Amazing.
Yeah.
And so tell us a little bit about how the interest that you had for surgical oncology evolved towards breast cancer.
That was by accident. I would say since I've been here, just because of the numerical nature of the disease, it's roughly 50% of our clinical volume. I came here planning to be, and for a large part of my career, being very general in my surgical oncology scope of practice. I gradually narrowed down because our department was never more than 3 or 4 surgeons. We're now up to 8, and at some point, particularly as you get up into the ranks, you've got to make room for other people. And so I never had a high profile in upper GI surgery, and so that quickly went under Alan's tutelage to Dito and to a couple of other my colleagues. The pelvic surgery, which I've done a lot of, I've probably done 50 or 60 pelvic exonerations in my career, and I got that from Toronto and from Alf Ketchum. Thankfully, we're not seeing much of that anymore because the disease is being caught a lot earlier.
Yeah.
But I will still do some of that. I still do a little bit of head and neck, some melanoma and sarcoma surgery. I still, the general surgeon in me tells me that to subspecialize, unless you're a Bernie Fisher where you have this huge research complex that goes with it, leaves you open to complacency and boredom, and those are lethal. So it's the breadth of practice that keeps you on your toes and keeps you interested and engaged.
Yeah, and so, but the majority of your patients are women who had a mammogram and there's something suspicious that was identified, or they identified a mass and we, you know, got to see a internist or their regular physician, and then or gynecologist for that matter, and then mammogram took place and something was found and the patient comes very anxious to you. That's one of the toughest news that anybody can imagine. So how do you deal with that? How do you manage both the procedure to be done and the anxiety of the patient at the time they come to see you?
Well, that's where Alf Ketchum came in so well. He was absolutely phenomenal. We would see from 8 a.m. until 8 p.m. 60 to 70 patients a day. Every patient who left his office swore that he'd spent 20 minutes to half an hour with them. Mathematically impossible.
Yeah.
But it was the art of medicine, and I've been very fortunate in having a lot of very good people, but he was without peer, and so I basically I've tried to emulate what he did, because I think he caught exactly the right balance in terms of the relationship with the person, as well as dealing with the complexities of the disease in a way that they understand and can relate to.
Because really you have a spectrum of possibilities, from totally benign cyst or whatever to a very aggressive tumor.
Correct.
And that finding, that process of discovery of really what's going on is in your hands. I mean, you are with the pathologist, the rainmaker of the life of the patient at that point. You identify the tumor, you essentially circumscribe it, you remove it, and you pass it to your colleague pathologist to come up with a series of tests that they do ex vivo to try to characterize the tumor as well as possible.
Correct.
And how do you go to the next step of letting the patient know what it is? Obviously, if it's benign, that's very easy. If it's a malignant tumor, it's much more challenging. So how do you go about to communicating that?
Well, I think the only way to approach it, I think, is from a realistic, optimistic perspective. I mean, for the first time in history, breast cancer mortality's fallen, and that's a function of many things, but primarily early detection, and much more powerful, much better tolerated chemotherapy. And so the game that we're playing is to match the treatment to the tumor to optimize the prognosis. And we see a lot of stage 3 breast cancer here. It's actually one of the things that makes breast cancer here very interesting, because those are challenging cases. In 1984, when we saw a case of inflammatory cancer, there was a 90% chance that woman would have expired within the first 24 months, be dead before 1986 was out. Now we're achieving survival rates that are approaching 50%. It's still a serious disease, but what a difference. And I think the important thing in that setting, which is perhaps the most dire situation we face other than, frankly, metastatic disease, is to emphasize that, because it's our job to prepare people for what is going to be a difficult ordeal, but to prepare them and tell them that this is nothing more than a long-distance run, and you just simply have to outlast it. And they do very well. It's amazing. You take someone who knows nothing about a disease, the personal courage that they can muster within themselves to see their way through to a successful outcome.
Do you think that that the outcome depends a lot on the attitude of the woman and on their decision to beat that disease? Absolutely.
Can't prove it. Alf Ketchum was asked this time and time again. He's right. You cannot prove this, but there is no question that if you can get someone through the initial shock, and you appeal to all the better angels of their nature and sort of fortify their courage, they're going to do much better. Even if things don't go well, they do better.
Tell us about the story of a patient, without names, of course, that really was particularly meaningful to you for any reason. Can you think of that?
Well, there's a lot of them.
I bet.
Yeah, there's a lot of them. The ones there are two or three, and I can sort of put a composite together of their stories. Folks who've had a bad cancer, sometimes with an unknown primary, a lady who presented with axillary metastases in one setting that we couldn't relate to anything, that didn't look like it was breast, didn't look like it was lung, who then metastasized to the neck.
Yeah.
So did radical axilla, radical neck dissection, lots of chemotherapy, lots of radiation therapy. She's alive and well 10 years later. Two other ladies who have had bad breast cancers, one of whom went on to get a post-radiation angiosarcoma, who ultimately died of their diseases, but throughout, at every step of the way, they looked it square in the eye and they did not let it beat them. It may have taken them ultimately, but it never beat them. So it's really, it's very impressive the way human beings can step up to the plate when they are, when they themselves have it in them to do that, and most if not all of us do. It's a question of just trying to bring that to the fore. I mean, you can tell all of the pessimistic stuff. People don't want to hear that, nor should they have to hear it.
Yeah.
I think what they need to be told realistically.
Yeah.
I'm asked, for example, I'm asked perpetually, what's the percentage of survival for this, for the survival of that? And I said, you're telling me that there's such a thing as being 20% pregnant. You can't be. You're either going to survive or you're not.
Yeah.
And what we're doing is we're stacking the deck as far in your favor as we possibly can to make sure you're on the survival side.
Yeah.
And I think if you approach it from that point of view, things become clearer and people sort of settle down and they look at this thing and say, we're going to get through this long distance run.
And you have built at UM with your colleagues what is probably one of the premier center for women with breast cancer, where you have a team of physicians who actually look at each individual case and determine what is the best approach. Some tumors you cannot do surgery on.
Right.
The chemotherapy, the radiation therapy, etc. Explain a little bit how that works in terms of that team approach to the disease.
There's many different ways of doing it, multidisciplinary care. I think the very best among us have always done it, going back as far, certainly in my time in medicine. We haven't called it that, but the fact of the matter is that none of us can function successfully in isolation. It's simply not possible to do that. And the medical oncologists, and we have had an excellent working relationship, and same with radiation oncology over time. And we will have meetings, but I think actually the more important thing is not the meetings themselves where you discuss patients formally, but it's the backroom discussion where things actually happen and patients get transferred one hand to the other on the same day, not infrequently, and we just simply get the job done. It's a question of doing what's right for the patient. With all of the new information about BRCA breast cancer, HER2 breast cancer, more and more we're starting to treat with the medical treatment up front rather than the traditional post-operative adjuvant therapy. The advantage being that if you've got a measurable tumor, you actually can do a bioassay and make sure that disease responds to that treatment.
Yeah. And
if you fail to get a positive bioassay, you have the opportunity to switch. The other way, it's just a Hail Mary pass and you hope it works. So there's a lot of changes going right now. We're increasingly starting to do, and I've been a fan of this for a long time, both in sarcoma surgery and in breast, that I think that the systemic adjuvant and sometimes the radiation adjuvant therapy is better given preoperatively. There's been a long myth that when you irradiate tissues that the surgical complication rate goes up. That's true if the radiation was 10 years ago. If you've irradiated a sarcoma now and operate 4 weeks from now, they heal just fine, and they do fine.
Interesting.
Yeah, the radiation biology is totally different at those two time points.
Fascinating. And there's another dimension of you which is extremely important, which is your reputation as a outstanding surgeon and the role model that you represent for your young colleagues who are entering the field. And I'm amazed to see the number of our students at the middle school who decide to go to surgery, and obviously you have a big impact on them, and you provide that role model that will help build the next generation of great oncologic surgeons. What do you think is the most important message that you can deliver them at the beginning of their career, at the dawn of their career?
I would, my first message is a counterintuitive one, and that is that lifestyle is vastly overrated. I have seen too many people, and this really started in my generation, and we were getting some of this as we were going through medical school. Too many people who overvalue that at the expense of doing what is their real passion. I've seen too many people who have backed away from a career in surgery or another very high investment career to do something else because of this. And I won't tell you which disciplines they go into, and you can read between the lines.
Yes.
But I'm repeatedly impressed by the fact that when you peel back the onion and you look at people, that there's a real regret there 10 years afterwards that they didn't go for their first choice. No matter what you do in this career, you're going to spend a lot of time doing it. So make it number one. You'll figure out the rest. Once you do, you become a surgeon, the rest will figure itself out.
Do you have any regret of things that you would have liked to do that you didn't do in your career?
I've had sort of around the edges, yes, but the big things I have no regrets. Coming back to Miami was probably the best thing I've ever done.
One thing that's extraordinary is that your life is a you know, phenomenal window to the progression of the management of tumors. In this case, you know, many different tumors, but one in particular that you have followed the closest, which is the breast tumor. And as you said, it's such an amazing progression from, you know, a story of failure to a story of success. Mm-hmm. And you know, I can tell you that from the patient side, having had a very close family member who had developed breast cancer in the late 80s, and I remember looking at my textbook, Harrison textbook of medicine, mm-hmm. As a good internist at the time, and saying, you know, the prognosis that was for that specific condition pretty dismal. Mm-hmm. And it turned out to be completely different from what was in the book, because the science had advanced so rapidly. It was not really, correct, you know, in the last edition yet. Yeah. And that's an extraordinary opportunity to witness such a progress.
Well, now that you mention it, to go back to what you asked before about a patient, when I was a fellow, and I was halfway through my fellowship, it was June of '85, an old patient, Dr. Ketchums, came in, and he was a melanoma patient, had 5 recurrences on his cheek. And he came in, no appointment. He was covered from head to toe with black spots and subcutaneous nodules, and the melanoma had systematized. And so at that time, all we had was DTIC, which was very toxic chemotherapy. And this guy was 76 with the usual comorbidities. So he heard out what we had to say, and he said, "Thank you, I think I'm going to get myself a 6-pack and find a key, a dock in the Keys," which he did. And so I never saw him until 2 weeks before I went back to Toronto, when the same thing happened again. He walked in, and everywhere where there'd been a black nodule was now as white as your coat. It was vitiligo. And he was well. He was healthier than he was the last time we saw him. So we really had 2 questions. Where the hell was that doc, and what kind of beer were you drinking? I mean, it was the most, it just shows you how capricious cancer can be. And I can juxtapose that to another story in melanoma. It's easily the most unpredictable tumor we see, with the possible exception of renal cell carcinoma. And this was a lovely 35-year-old registered nurse in our surgical intensive care unit. And we get to know those folks very well because, of course, we interrelate with them all the time, particularly the trauma guys. And she had this little tiny spot on her, I believe it was her thigh, 0.7 millimeter, which is early melanoma. The survival rate is 98%. And within 18 months, she was dead of widely metastatic disease. So it shows you that you've got two extremes there, and it just shows you what you deal with, and you have to be prepared for both.
You know, I was fascinated to look at the work done by Tan Incy in our Department of Pathology, where he takes a breast tissue that he expands in a petri dish, and then provide the cells with two different environments, and then transform them with a consistent oncogene, and then look at the tumors that are being formed, and depending on the two conditions, he ends up with two completely different tumors, one that is very aggressive and the other one that is a tumor that is essentially very controllable.
Yeah.
And I mean, that is such an amazing, you know, development in our understanding of breast cancer, is to figure out, you know, what determined the difference in aggressiveness, exactly as you described for melanoma.
Yeah.
I think that's going to be a huge progress.
Well, it's evidence of what my first mentor in Toronto, Rudy Falk, said, is that it is highly likely that we are going to fight cancer to a Mexican standoff. That we will have people who live the rest of their lives with tumors that are being held at bay by some biological response modification that is durable. And I think he's likely right. I think that's where we're going to wind up in a substantial proportion of what we do.
Do you think that one day we're going to be able to address all forms of breast cancer in a way that would be, you know, successful in 99% of the case? I don't want to speak about a few, but
well, I mean, look what we did with polio, and you know, I mean, it's these little insights that occur as a result of convergence of circumstance and chance. You know, Einstein's glimpse of brilliance was in the general and relative theories of general and special theories of relativity. These things happen, and at some point somebody's going to find something that leads us to a solution which basically takes a lot of the mortality out of play permanently. I think that will happen. It ain't going to happen tomorrow, but it'll happen.
Wonderful. Well, listen, I want to take this chance. You're an extraordinary surgeon, a beautiful human being who has done so much for your human fellows. And one of the privileges that I have is, as the Dean of the Miller School of Medicine and the head of our health system, I want to thank you for what you do for your patients, for all of us, and also for the reputation of our school and our university. Your career is a illustrious career that, you know, will impact your field, our lives, and the future of medicine forever. So on behalf of the Miller School of Medicine, I thank you for what you do. It's extraordinary to have you as a master of surgery in our university, as a master of oncology in our university. And I wish that you will continue to do what you do for many, many more years, because it's God's work. Thank you for what you do.
Thank you. It's a good place to work.
Great to see you.